topic for today, how might behavioral science resuscitate healthcare, is a big one. It's inspired a lot of questions. One, being how do we fully put humans at the center of healthcare, which seems like it should be obvious. But as many of us know, this is not necessarily something we're always seeing or what's necessarily happening today. So we've seen over the past 3 years that through the pandemic, there are cracks in the healthcare system. And I think more than ever, patients, providers, we're looking for change. So today we have an absolutely incredible panel who will talk about how we might go about developing a more person-centric healthcare system. At its core, we'll look at how the principles of behavioral sciences, of design, of some other disciplines should be at the core of these solutions. So what we're going to do, I'm going to introduce my colleague in a sec, Ada Lee. She's going to give a presentation that dives into how behavioral science can be applied to think differently about healthcare. From there, we're going to have a panel discussion. We'll introduce our panelists, and we will certainly offer the opportunity for some Q&A from the group. So, but to get things started, first off, we're going to post a poll in the chat so we can learn a little bit more about all of you who are participating. So the industry you're working in, as well as where you're joining us from today. So definitely dive in on that. And please use the chat throughout all of this. If you have questions, comments, we'll certainly look to address those as best we can. But now, for those of you who are not familiar with BEworks, so BEworks is the world's first management consulting firm dedicated to solving business challenges using behavioral science. The company illuminates the unforeseen factors that influence everyday decisions to build life-changing solutions that make people happier, wealthier, healthier, and greener. They work with leaders in financial services, healthcare, sustainability, and anywhere else there's an opportunity to help organizations better serve their customers and clients. Ada Lee is their Vice President of Healthcare Strategy, and she's a seasoned expert in behavior change. At BEworks, she oversees engagements primarily in healthcare. Her broad sector expertise and strategic oversight gives her a unique perspective into how organizations can more deeply and accurately understand consumer needs. So I'm thrilled to introduce Ada, who's going to take us through her presentation on how we can apply behavioral sciences to healthcare.
I'd love to start the webinar today with a couple of thought starters before we dive into the panel discussion. And I hope that some of these themes that are raised through this presentation we can go back to, or maybe there are already thought starters that everyone can start to ponder throughout this session. So let's get started. So it's really no secret and almost common knowledge now, I think, that we really need to think differently about healthcare. Over the last 3 years, throughout the pandemic, that this time has really shown us how truly broken our healthcare system is. It's surfaced a lot of the long-standing issues that the healthcare system has faced, over the last 10 years, 20 years, or maybe even before then. But what's happened is that ever more so, it's in the limelight. So before I begin the presentation, I'd love to hear from all of you. We're going to have one more polling question that's going to pop out now. So the question is, which of the following healthcare system issues do you care about most or believe is the most pressing to address? Now, of course, it's become abundantly clear, as I mentioned, that something needs to be done to improve our healthcare system. Whether we are talking about bigger or smaller changes. And the changes really, I think many of us have the sense is that they're kind of needed across the board, from improving the delivery of care to providing better support for patients and healthcare providers to reducing administrative efficiency and access problems. And of course, the question is, why now? So as you finish off filling out the polling questions, again, take your time, no rush. Let's talk a little bit about why now. Now, On the screen here, for those of you who have finished responding to the poll, you can see here on the screen that these are just some articles that you can easily find just by searching in Google, healthcare system broken, and then you insert a country name. And it's not specific to North America. It's quite global. It's been a long-standing problem. And COVID-19 has brought to the limelight in a very public, within the media, right, a public way, what the challenges are. And of course, a lot of these challenges, there's many dimensions to it, as you can see the dimensions in the polling question. But the consequences can be really dire. I'm zooming in to the article that's on the right, that was on the right-hand side, and this was in the US. The consequences can be so dire that patients who are stuck within the healthcare system can end up dying from perhaps, to put strongly, some of the failures that our healthcare system has presented to people. And it's not only journalists and the public who are talking about this matter, right? Experts and academics are concerned about this as well. The screenshot here is an review article published just last year, which outlined the various problems within the US healthcare system, ranging from access barriers, uncontrolled prices and costs, unacceptable quality, widespread disparities and inequities, marginalization of public health. And what's really interesting to me in this article is that there's a call to action for coherent national health and public health policies that are based on evidence-based science and not political pressures. Pretty strong. Now, this article was based on the US healthcare system, and Canada is perhaps just as bad. In this study that was conducted just last year, they looked at 11 high-income countries, Australia, Canada, France, Germany, Netherlands, New Zealand, and more. US is part of them. And in Canada as well, we are also not doing so well with access to care, the care process. Equity is still a problem, and administrative efficiency is yet a problem as well. And of course, this is, again, a long-standing problem. It's not new, but we haven't been able to crack the nut, it seems. And of course, there can be many reasons why, but some of the reasons is that, well, change in general is hard. On an individual, personal level, humans in general tend to stick to the status quo. And this status quo bias is one of the most predominant biases that we have as humans, especially when things get complicated, we get busy, we're strapped for time, and there's more urgent things to attend to. The easiest thing to do is to stick with what's already been done and things that we've already been doing for a long time, reverting to our habits. And related to that, change is risky. So as humans, we are naturally risk averse. So the status quo, the current state might not be so great, but maybe it's not so horrible either. And the current system somewhat functions, but maybe it kind of works. So it's hard to justify putting in a lot of time and money and putting in that risk to fixing something that maybe we don't see a reason to do so immediately because it's a little too risky. And lastly, we are very present focused as humans. So, this is called the present bias. Planning and acting for the future, especially far future, is really hard. It's much easier to think about and satisfy our present self. And all of these psychological factors, and there's more, these factors at play prevent us from changing as rapidly as we hope. But, I would argue that despite these psychological factors that make it hard for us to change, we are ready for change now more than ever. The pandemic has created a huge motivation for us as a society to change, and it's clear that people are eager for change. The pandemic has shown us what's possible. There was faster development and approvals for vaccines. Healthcare communities got together globally to solve a problem. There were advancements in health technology to adapt to people's isolation needs. So for example, the acceleration of virtual and digital care. And perhaps by coincidence, the advancements of other technology, such as metaverse, that can now be used to healthcare's advantage. And here are just some snapshots of how eager people are for change, right? These are articles from earlier this year and dating back to 2020. Lots of people are coming out, regular citizens are coming out to say, yes, we really want change and we want it now. We really think it's worth the money and the effort to fixing our healthcare system for the better. So here are some thought starters for our panel discussion on how we can start thinking differently about health. There's a couple of dimensions that we can think about. The first one is the question of, well, what is health meant to solve for? Who is it meant to solve for? Is it meant to solve for patients? Or is it meant to solve for people more generally? Or is it for business purposes, revenue purposes? One can argue that healthcare without the patient is meaningless. Healthcare without people are meaningless, and we need to become more patient-focused. But perhaps beyond thinking about patients as patients, maybe we need to think about patients as people first, and that we're trying to treat people who have a full range of life and have people in their lives, other people in their lives, and other moments in their lives beyond this particular moment that we are interacting with them. I had a really interesting conversation with Professor Paul Snowden, who's at McMaster University, and this happened a couple of weeks ago. And he founded a company called Working Theory. You can check him out if you'd like. Really cool guy. And we had a discussion about what does person-centered care mean, and what is the implication of this for changing the healthcare system, how hospitals work, how patients go through this journey. And really the components that we discussed were, well, person-centered care is important. Of course, delivery of care is really important. Quality of care is really important. But there's this third component that has been missing and that we haven't put as much effort into thinking about and to develop. And that third component is compassion and empathy. Really, it's about thinking about the psychology of the person that you're treating. It's not just about providing people with the information that they need, but it's all about, also about considering people's desires, their values, their family situations, their social circumstances, their lifestyles, seeing people as individuals and working with them, right? And having this empathy about their lives, working together with them to develop the appropriate solutions. The next dimension we can think about when we're thinking about how to change the healthcare system is to think about the type of health that we aim to achieve. Is it curative? So when people get sick, we treat them. Is it palliative? Or is it preventative? Now, if we want to become more people-focused, maybe an argument could be that we need to be more focused on preventative health. People have lives before, during, and after the moment that we're treating them. And arguably, our aging population has caused a societal shift, a societal need to shift to a prevention focus for health, right? Why fix things when they're broken when you can prevent them from breaking in the first place? The last dimension that we can think about when we're talking about changing the healthcare system is the approach to changing people's perception and behavior. A very standard approach, of course, is to provide good information and education. But perhaps there are other behavioral interventions that we can put in place as well. And I'd love for our panel discussion to think a little bit about these behavioral interventions. And I'll give a quick example here momentarily. Now, the key here is that information, incentives, depending on where you are in the world, incentives and behavioral interventions aren't competing approaches. Rather, they are complementary. And here's the reason. We know from lots of research that information is very effective, of course. We need to provide people with the right information, the right education, so that they can have this informed decision-making for themselves. But what's really interesting, as you can see in the screenshot here, here's just one of the articles that have come out recently, that 60 years of research says that patient education and information is effective. But the effect size is only moderate, which means that there's still a gap to close in terms of providing this information to changing actual patient experience and behavior. So there's a gap. And what can we fill into this gap so that patients have a better experience, healthcare providers have a better experience, and that they're able and better supported to change and shift their perceptions and behavior. So, all in all, we can categorically say that, awareness campaigns, information, education, potentially incentives also are a way to motivate people based on rational and economical reasons, right? Giving people the knowledge, helping them weigh the pros and cons. But the gap could be some of these irrational or irrational reasons that are not so easily addressed through information. And some of these irrational reasons or psychological factors might be emotional or social cognitive factors. And these might be better suited for behavioral science approaches. And the solution for, based on behavioral interventions can be actually quite elegant and simple. One of my personal favorites is this one. So this image here is an image of a scale. It's a scale that you go on to tell you how much you weigh. But what's really cool about this scale is actually it's numberless. So it doesn't actually tell you how much you weigh. And this scale was developed by our co-founder, Dan Ariely, with another company called Shape-A. And it's a numberless scale that is yoked to an app, and it shows color-coded feedback about people's weight loss progress. So if you're on track, it'll tell you that you're on track, keep going. If you're ahead, it'll tell you that you're ahead of your progress. If you're a little bit behind, it'll tell you a little bit behind. But critically, it won't tell you the exact numbers. And the idea behind this, the psychological rationale behind this, is that people tend to get very distracted and unmotivated by the small fluctuations in weight. So these small fluctuations usually have nothing to do with people's exercise or diet plan, but rather they kind of reflect the time of day, the meal times, water retention. If you're female, it might be due to menstrual cycle, for example. So imagine that you've exercised, 2 days ago, you really spent a lot of time on the treadmill, lifting weights for a long time. And 2 days later, you see that your weight has gone up by 1 pound. That's quite unmotivating. But the problem is that this is not really how the body works. It takes time for exercise efforts to show. But nevertheless, seeing this number, your weight increase, can be very unmotivating because you put so much effort recently into your weight loss. So these fluctuations in weight are distracting information, but nevertheless, they affect people's behavior. So what do we do about this? Well, we then remove the weight information and provide just color-coded feedback. And what we found is that what's really interesting to me is that people are actually more likely to lose weight with this scale than the standard scale. So that's one idea. So how can we get started? In the last 2 minutes or so, here are some additional thought starters for our panel discussion. And of course, to the audience, if you have any interesting ideas or comments or questions, please feel free to put them into the Q&A chat for us. Now, there are 3 main things that we need to think about when we're thinking about what to do. The first one is diagnosing the problem. Why? We need to think differently about the barriers to changing healthcare systems. What are these? Now, personally, I find it easiest to think about it categorically first. First of all, there are environmental or systemic behaviors. So, these are barriers that are not specific to the individual. They might be barriers that are, access or lack of information or policy. So this is not due to the individual, but rather things that are in their environment that constrain people. So, again, these could be access, information, or policy, or you could probably think about more, right? Regulations, etc. At the more individual level, there can be psychological barriers. So if we break that down, there can be social barriers. So this is thinking about what are the social norms of behavior, what are the expectations being imposed on people, and how much do they value the opinions of others. There can be cognitive barriers. So how hard is it for people to change? What's perceived as easy? What's perceived as hard? What hassles are there? What's the status quo? What are some existing habits? And how long have these habits existed? Third, emotional barriers. So, is there a fear of the unknown, fear of unfamiliarity? Is there a fear of change, fear of risks or regret? And oftentimes, these systemic or environmental barriers can influence the individual psychological barriers. And so the point here is that changing the healthcare system is not solvable by behavioral science alone. Behavioral science is really great at tackling these social, cognitive, emotional barriers, but ultimately we're going to need a multidisciplinary approach to the solution. And that's why I'm so excited by all the panelists that have joined us today to offer this multidisciplinary view on changing the healthcare system. Now, if we take even a step back beyond the immediate solar system, if I can use this analogy of these planets, right? There's the solar system of healthcare provider barriers that they face. There's the barriers that patients face, payers face, and more. And we can think about how the barriers for these different groups of people can affect each other. So an example from the work that Eric and I, he's a panelist on the team for today, but Eric and I and our team, what we've uncovered is that a lot of times physicians will not want to change if they suspect that patients will push back really hard. So patients may feel very hesitant or fear around changing their treatment plan. And so maybe healthcare providers don't want to fight that. Lastly, last 30 seconds, some other things we can think about is, well, what would a patient-centered or person-centered healthcare system look like? What are the principles? And here are two things to think about. The first one is, well, perhaps we need to start by understanding the psychology of the patient. What are their psychological needs? And we need to remember that emotions play a much bigger role in people's decision-making than we think. Secondly, for behavioral solutions, we should absolutely think big. How can we do to change the system as a whole? What if there was no system? What if we had to start from scratch? What would it look like? But from a practical standpoint, in order to scale it, maybe we need to start thinking small. Big idea, but what are some of the small things we can start doing today? What are some of the quick wins that we can start implementing today so that we can scale it over time? And that's about it. I'd love at this point to hand it back over to John so that we can dive into the panel discussion. Very much looking forward to that. Thank you so much. And over to you, John.
Thanks so much, Ada. That was terrific. Yeah, something definitely to dive into. I was struck by when you talked about us being so kind of present focused and the tension that comes alongside of that of a healthcare system focused on prevention, which obviously impacts things far into the future. Maybe that'll be something we get into or not, but it struck me as a tension there. Before I introduce the panelists, it would be interesting to quickly just see the poll results to see who we have with us, where they're located, and then, of those considerations that Ada posed, what's most important to folks. So great, it looks like we have a range of folks from across the industry, lots of others. We'll break that down later on, I hope. And nice global mix. North America and Europe represented with one participant from the Middle East. So thank you for sharing that. And then on to our considerations. So it looks like, well, we have a nice distribution here. actually, but poor access and high costs being one of the most significant issues, as well as the kind of poor quality, or dare I say inconsistent quality of care, amongst others. So that's good for us to keep in mind as we dive into the discussion a bit. So thank you all for chipping in your thoughts on the poll. Now I'm excited to introduce our panelists today. I'm going to go quick on the bios. You can find out more from them, kind of offline afterwards, because I want you to hear from them, not from me. But I'll run through this really quickly. So first, I'd like to introduce Jeff Fair. He currently serves as Consumer Director and DTC Lead at Pfizer, supporting the cardiovascular and metabolic category. He brings to our panel over 20 years of patient and consumer marketing experience in both the pharmaceutical and CPG industries. So welcome, Jeff.
Thank you.
Dr. Jia Hu is the CEO of 19 to 0. He is a family physician and public health and preventative medicine specialist. And for those of you that don't know, 19 to 0 is a not-for-profit he founded during the pandemic focused on health behaviors change. So welcome. Joining him from 19 to 0 is Teresa Tang, a co-founder and operations lead. She previously held a position at Alberta Medical Association, working on population health and primary care initiatives. So welcome, Teresa. Maura Cass is an executive portfolio director at IDEO, a leading global design and innovation firm. Maura co-leads the North American leadership team, whose purpose is to use design to solve some of the most complex challenges in health and well-being in service of bringing equity, dignity, and joy to all. So welcome, Maura. And last, but certainly not least, is Dr. Eric Rote. He is an advisor at BEworks and a clinical psychologist whose work focuses on developing solutions that would solve psychological and behavioral challenges that patients and physicians face within healthcare. Whew. Okay, welcome everybody. And now we can get into it. So, for our first question, first off, if you'd like to tell us a little bit more about yourself and what you're working on, great. But we'd love to hear about something that you've uncovered or developed that you're working on that's inspired you. And then from your perspective, we've talked a lot about, again, kind of human or person-centered care in Ada's presentation. Would love to get an initial thought or example from you on what human-centered or person-centered in healthcare means today. And I think I may tee it up. Actually, I'll offer a volunteer, whoever wants to kind of jump in here, and we'll get going.
So John, I'll take the first round and try to provide a thoughtful answer. I think one thing that has inspired me over the past couple of years, and it's some of the work that we've also had the pleasure of working with BEworks on as well, that is going to be probably common to many people on this call and my fellow panelists, is the area around health equity. And we know, for example, if we look at the United States, about 1/3 of our population identifies as Black, Hispanic, or American Indian. And yet there are significant disparities within these groups across the board. Everything from access to use of healthcare resources, to insurance coverage, to quality of care, to health outcomes. So going back to some of the points that Ada had raised, there is a huge need for focus, but I would also suggest that there's a huge opportunity that we have as well to help improve patient outcomes by thinking very deliberately about the way that we're thinking about health equity and healthcare disparities across the board. So I think that's one area that has provided a certain degree of inspiration and also opportunity that we can collectively think about it. It's not necessarily one stakeholder that is going to crack the code or be able to address all of the issues. And I think in what Ada was describing with HCPs, patients, and payers, I'd suggest it's a combination of stakeholders that really can collaborate and think about how we can move the ball forward in terms of improving outcomes, particularly within underserved communities. I can pause there and have other people answer the question however you would like to facilitate.
Yeah, absolutely. Yeah, that's a wonderful start. Do others have similar thoughts or can build upon what Jeff was talking about.
I can add from our not-for-profits, so our 19 to 0 team, we originally were built around this idea around kind of health behavior change and encouraging safer public health behaviors originally during COVID, but now have shifted to a range of other healthcare challenges as well. And I think what was really inspiring for us actually was to see this magnetic effect of all these different industries and all these different sectors coming together to try to understand problems and then try to solve them and work together. And what we've seen is that the pandemic was a great excuse for people to come together from industry, from marketing, from healthcare, from communities, even vulnerable communities like Jeff had mentioned. But we've seen that actually stick within the 19 to 0, at least, environment. We've seen that people are still interested in actually what the pandemic has taught them and what they can continue to do together within the healthcare system. And so I think for us, though, what we uncovered from just public health as one of the issues that came up in the polling was that, there is this one size fits all approach to a lot of the solutions, a lot of the communication. And so where we really started seeing this gap was this lack of tailored, targeted, kind of focused, thoughtful intervention that was thinking about how do I reach the people that really need to actually be reached, to Jeff's point, and that need to actually have support to shift their behaviors to a safer public health behavior. And so when we think about what human-centered really means for us, it's always been about how do we understand what North Americans or people are doing around the world around their health behaviors? How do we have them weigh in around what would actually motivate them to change and how can they be part of that solution, to add as points even earlier around some of those principles? And then how do we design public health messaging or solutions that actually is tailored to the people we actually want to reach instead of this one size fits all? And so, to hit off a couple of your points, John, I think that's what really comes to mind when John and I are starting to think about, what have we learned over the last couple of years?
Thank you so much, Teresa. I know Eric was eager, so I'm gonna tee him up.
Yeah, I'm excited because Jeff started out with a very big macro lens. Teresa gave us a nice view about how that macro lens blends into individual behavior, and I guess I'll take the micro lens and talk about something I've been always amazed to see in my work in clinical psychology is how much the individual cares about their own life and how much they can do when given the right conditions and the right information. And so to both Jeff and Teresa's points, I think a good mental model for thinking about how to make human-focused healthcare endemic is to think all the way from the macro, all the way down to the individual. Not only are there ethnic, geographic, financial, experiential filters that make a person value or perceive different healthcare outcomes or experiences differently, there's individual ones. And so we can choose how closely we want to focus. And I think maybe I'll champion that viewpoint as we go through today.
Amazing. Thank you, Eric. Maura, any thoughts on the topic?
Yeah, I mean, what's coming up for me as I think about this and coming into this conversation as a designer, as someone with a background in anthropology, but someone who's really passionate about change, as we all are, the conversation actually that stretches across what everyone just said, the thing that I'm most inspired about is actually the data that we're using to really understand what the real problems are. And by that, I mean, so often we've looked at very quantitative data and coming from very specific sources that have not been inclusive actually of many different experiences or many different inputs. And what we're seeing now is a shift around thinking about who's making those decisions, what data and voices are they relying on, and ultimately who has the power and understanding of what needs to go forward. And I think, what is interesting from the multidisciplinary perspective that Teresa just shared, that is, we're starting to see shifts from just patient advisory panels to actually looking at having a room full of people that represent all of the stakeholders, right, as individuals with their experiences, like Eric just mentioned, but not just having folks within the organization making those decisions, but having everyone that's actually part of the service model sharing what's happening and having the opportunity to shift from their mindset of what they experience to actually understand what the other side of that problem might be, and therefore a new emerging need. So that multidisciplinary, sharing individual stories and actually building a larger range of the stories that we're listening to is really starting to shape a different future vision for health.
Yeah, definitely some themes around listening, which is a big step, and collaboration. Definitely hearing that come through. Gia, you definitely want to give you a chance to weigh in here before we advance the conversation.
Oh yeah, I mean, I kind of agree with what everybody has said. I mean, perhaps echoing some of the things spoken by the others, I do think what really inspired me, and this is sort of a repeat of what Teresa is saying, is that at least during the pandemic, and hopefully a little bit into the future, though it remains unclear, you really did see everybody coming together in all sorts of interesting ways, right? So at least in Canada, we saw industry, and not like the pharmaceutical industry alone, but big companies working together with little NGOs to provide vaccines for people, right? And I that is one of many examples of, I think, just groups who all have a stake in healthcare actually working together on the issue because it was just so compelling and so critical. And it's also a sort of like it sounds kind of crazy, but public health is forced to work with other bits of the health system, which is not normally the case, at least in Canada. And any sort of de-siloing like that is really wonderful. And I think it just shows that, stuff like this can happen. The question remains, I think, what will enable these things to happen when the world isn't falling down around us, and that's where a lot of the hard work needs to be done moving forward. So I guess sort of inspiring, but also a lot of challenges in the road ahead. So
yeah, that's a great point. It actually feeds into the next question I want to raise to the group, which is around what's a realistic goal for us, or a measure of success for achieving human-centered care? A few of you alluded to it a little bit already. I would say that maybe it's engagement, right? Or people engaging in their health. Eric, you used the word actually making it endemic. I'd love to unpack what that means. But what's a realistic measure of success for achieving more human or person-centered care in your mind?
I'll quickly start with a broad, vague idea that people can build on if they wish, but I'm not sure how we measure this. But I mean, if we think, again, as a mental model, we think about how the medical system operated in the past. Maybe medical advances and technology was not as advanced as it is now, but one thing that was there that isn't always there in the modern medical system is a personal connection with your healthcare team. So if we think about 100, 150 years ago, your doctor grew up in the same town as you, maybe you went to school with the doctor, you knew your family or she knew your family, and there was an ongoing relationship which built trust. I think as we start to think about how to build that into or replace it in the modern system, it gives us an idea about what human-centered care can feel like, feeling like either a healthcare partner or the system as a whole knows you, understands you, cares about your viewpoint, to get to some of what people are saying in a holistic way rather than simply curing an isolated problem. And I think that gives us a broad mental model to think about as we look at that.
If I can, I'd like to pick up on the points that Eric brings up, because I think they're really, really important, and also maybe piggyback some of the comments from Gia and from Maura as well from the prior conversation. And that issue, many of us who have been working within healthcare aim to help facilitate shared decision making. And by its very nature, shared decision making is a two-way dialogue. It's an open conversation between patients, care partners, and healthcare providers. And to the degree that we can collaborate and work together and think about solutions that help facilitate those conversations, we can make a difference in terms of improving health outcomes for individuals. One of the issues that Eric pointed out, which I think is really important to amplify a little bit, is this issue of trust. And we hear this in just a real life example that occurred to me personally a few weeks ago in a study that we did, is the perspective that some patients have of being, as we say, quote, unseen and unheard. And there are many reasons for that. And many of my fellow panelists and many people on the call can elucidate better than I can on that. But I know myself as a patient, when last time I went for an appointment, it seemed as though the healthcare practitioner, first of all, had a very heavy patient load and had limited time. And that's a nature of our healthcare system right now in the United States. And also there was as much focus on capturing data for EMR reporting as there was necessarily on looking eye to eye in terms of having that two-way dialogue. And there are many other factors, of course, at play. Those are simply two of the low-hanging fruits, so to speak. But to the degree that we can collaborate and work together, as Maura was talking about earlier, thinking about the ecosystem, that it's not only the patient, it's also the care partner. It's working with the practitioner, working with clinical, working with payer organizations, working with advocacy and associations of how do we help support that discussion, build that trust between the patient community and the healthcare professional community that really can go a long way towards having forthright conversations, because dialogue and communication, as Ada said in some of our opening slides, is key. And being able to support that is going to be important towards being able to move further in terms of improving outcomes.
I'd love to add an additional component to what Eric and Jeff has shared. I think it's really important, this element of trust and shared decision making. And I think that in a lot of the work that we've done with many of our healthcare partners is all about what are some of the tools that we can develop to facilitate this shared decision making and to build this trust. And I think that these are definitely core components to creating or iterating on the current healthcare system so that we can make it better and make it more people-centric. And one of the interesting articles I read recently is that there's a complementary outcome that we need to focus on also as we're building it, is this idea of resilience. So what are some of the things that we can do today to protect the thing that we're building now? We saw some advancements prior to the pandemic, inching towards more person-centered care. But as soon as the pandemic hit, all of that fell apart because there was not resilience built into the healthcare system to maintain that as we went into over time into a period of stress on the healthcare system itself. So I don't have the full answer to this, but I think it's an important component to think about. We build it for a certain end goal, but also what is the things that we need to do to protect and maintain resilience of the new thing that we have built.
If I can build on that, I mean, one of the questions that you presented, Ada, in the share was, what is health meant to solve for? And when we think about the question you just presented, John, around what are the measures or metrics for human-centered care or people-centered care, we have to go back to what it is we're trying to solve for and what the definitions of the words that we're using. And we're often conflating in our conversation the medical system, which Eric, you mentioned, the healthcare system, and then health overall. And my belief is that there is work to be done around a larger sort of mental shift around the inputs into what we're measuring, and the realization that within the medical system even, but certainly within healthcare, there is art and science. There is intuition and creativity, and also process and fact. There are knowns and unknowns, and there's function and, importantly, emotion, which you talked about, Ada. And unless we start to kind of hold the duality around that and design for those, we might get stuck in the structures and systems that have been created already and not be able to make a leap forward to what we all are sort of alluding to, where we want to go.
If I could quickly add to that, there's been increased articles over the last 20 years about value-based care over procedural-based care. And I think that's a step in the right direction. If we think about folding in patient experience, preventative medicine, as well as acute medicine, and think about it over the course of a person's lifetime, it might be very difficult to measure, difficult to figure out how to rig payment systems through a lifelong value-based outcome process, but it would redirect healthcare and physician attention to the long-term care and the holistic elements of the person's life, so that you're basically receiving payment and based on how the person does as a person over time. And it makes you think differently about the care you're providing in the moment.
Yeah. So what's standing in the way of that? Because value-based care is something you just said, Eric. It's been talked about for quite some time. What are some of the factors or barriers that are standing in the way of a more person-centered health approach to healthcare?
Maybe I'll speak. I mean, a lot of my experiences in Canada, the way I often look to other health systems, and I truly think Canadians love hating on the US health system, but when it comes to things like this, Canada is literally the worst, I think, right? And I think within the Canadian system, which is far less advanced than the US system when it comes to things like value-based care or any sort of patient-reported outcomes, a lot of it is just, I think like maybe I'll say like a total lack of incentives in this space to make some of these changes, right? And I think that, I mean, it's not like incentives are the be all and the end all financial or otherwise, but it's really disparaging, I think, or sort of discouraging to sort of see the way patients are often treated within the Canadian health system. I mean, we tolerate very long wait times. Physicians can get away with booking 50 patients at 8 in the morning and having them just wait. And I often think like, wow, like if my bank did this to me or like my restaurant did this to me, I would never go back. And so I mean, I think that instilling some culture of a better culture of sort of quality linked to what patients are experiencing, and frankly healthcare providers too, right? Because I do think, you know, on the other side of the coin, a lot of them are super burnt out. If we can't change some little administrative things for them, it's going to go nowhere too. But you know, it's a big thing to solve, and I think that without some of that culture shift, and I don't know how best to achieve that other than sort of micro level, and then you have some financial levers up at the government level, what to do. But Canada, I think, really has the longest way to go out of probably any country I've ever encountered. Sorry to razz on Canada.
I know. So the time is flying by, and we actually have one question from the audience, which I'll pose in a second. But let's look into the future a little bit. And you know, Ada and I were talking about this question beforehand around, you know, let's imagine there was no healthcare system, and we could kind of build it from scratch. So it would be more human or patient centered. Like, where would you start? Like, what? You know, there's two ways to look at this, right? Like, what's the kind of low hanging fruit? Like, what's you know, obviously we need to do that and it'll just make things so much better. Or where, you know, what are areas that are maybe more acute or we need to focus on in this, you know, imagine the future of a brand new healthcare system. So I don't know, I mean, I know it's a big question, but would love, you know, we got this group together, so I'd be curious what folks think.
I'll throw one thought out just as a thought starter, and it's a word that came up previously, and that's listening. And I think you can look at a number of organizations, and I'll be optimistic about this one. I think a number of organizations, be it industry or nonprofits, are determined to really think about it from a patient engagement standpoint. And what I mean by that is thinking through the entire life cycle, all the way through clinical trial development to the point was raised earlier on how we communicate, health literacy standards, for example, making sure that what is provided to the patient community is actionable and meaningful to them, all the way through to how do we collaborate with third parties? How do we get outside of our shell, so to speak? And how do we recognize that we can be part of the solution, but we aren't necessarily the solution? So a number of enterprises, I think, have really harnessed this idea of thinking of the patient from the beginning all the way through. And I think that that's a positive step for us, because it endemically says that we want to listen, we want to understand, and we want to be able to solve outstanding needs that are there within the patient care partner and healthcare professional community. So I think those kinds of attitudes and those kinds of initiatives actually can help us build and improve more meaningful health systems.
Yeah, more holistic and connected view. I love that. Other folks?
I think building on even some of the earlier conversation we had, like, I think if I were to almost like start from scratch and rebuild, I think I'd really want to look at, you know, the incentives, like how John was saying, around human-centered care, what are our funding models, breaking down probably some of the conventional structures, to be honest with you. I think very simply, but not simply all at the same time. I think to make it actually easier for people to work together, both within the healthcare system, but also like other sectors, like we've alluded to as well. So whether it's across disciplines, in and out of the hospital, so between a community and acute care, between health and social services, like these are simple concepts, but practically seem very hard to actually operationalize, it seems like, having navigated the healthcare system. And so I think ways that we can make it easier for people to work together will help us that much better support this like common understanding about the problems we need to solve and then the solutions. And I think just like quickly, lastly, I would say, like, to not necessarily answer the low-hanging fruit, I would say what I'd encourage people to do, though, is actually rather than finding like always the low-hanging fruit or this like silver bullet solution, is to honestly start with the sphere of influence that you have. So where are you? Who can you actually build relationships? What problems can you solve within your sphere, and tackle those pieces that you can influence around you, so that a number of small efforts can collectively shift the many, many endless problems that we can all identify in our healthcare system. And so I think that's what actually comes to mind when I think is, I wish that more people realize the power that they actually had in the small spaces that we all influence. And so those are things that I think come to mind, John, when I think about the future.
Wonderful. Maura, I'd love to grab your thoughts on this one.
Yeah, I love what Teresa just said, and it sort of bridges to where my head went. I mean, if I think about that big challenge of if we were to start from scratch, one place that I would love to go to is actually to focus on and empower the informal caregivers that have existed within our society and our culture, and really fundamentally understand the process and experience of giving care. They build trust, they create safety, they understand the emotional factors embedded in having, positive health outcomes. And how might we learn from the way that they practice and deliver care and center them, and then build a system that replicates those behaviors and those practices outward. And most importantly, apply value to that, and pay them and support them for that work and build that around there. I mean, that would be a really interesting way to actually look at how we might reimagine how healthcare is delivered by focusing on those informal caregivers.
I love that idea, and it definitely humanizes it. And also, there's a level of understanding and personalization, right? When you start at that level, which should deliver better care to the individual. So love that suggestion. A lot of like very kind of focused, target, individualized solutions in our new healthcare world, which is really exciting to hear. Eric, your thoughts?
I'm excited about these ideas because I think both technology and the way the healthcare system is already moving are sort of supporting that. I was going to say, I'll say the same thing, but with a different perspective. I was going to say, if I was to start again, I'd like to decentralize care. So it's focused very much on the physician, and that's important. The physician is very important in healthcare, strangely, but I'd like to expand the so-called healthcare team out to things like non-traditional healers, like family members, and have those people. Maybe it's not as much we need to change what individual actors are doing in the individual's healthcare, but the interstitial communication between a family member and a doctor maybe needs to change, or the voice that a friend has at the table for somebody who's receiving care. So I'd like to decentralize that, put a lot more on the individual and their informal supports, and have the doctor simply do what that doctor is best able to do, and let some other elements of the healthcare system support the rest, which we're already moving in that direction, but we can move a lot faster and further, use more of the patient's network and also technology, I think, to support that.
I'd love to maybe jump in very quickly. I know we're running up against time now. We're almost at the end. Time is really flying, and tie all of this together. And I do see the question from the audience. I'd love to, and I think we're all kind of in the same theme along with this question. So the question I'm spotting here is, in building trust in healthcare between patients and healthcare professionals, what do we think about the use of avatars or virtual mentors or two-way virtual communication that can help to build trust with patients? And I find this question really interesting because I think, themes that Jeff brought up and Teresa, Maura, and Eric, I think where we're kind of, my sense is that what we're landing on is, number one, we need to shift our focus from historically the demand side, solving for the demand side to supply side, sorry, to the demand side, which is patients and healthcare providers. And in this shift from the supply side to the demand side, we can think more about the life cycle of the patient, life cycle of the healthcare provider, how technology such as two-way virtual communication and avatars and virtual mentors can fit within that. Where do other systems and informal caregivers and their life cycle intersect with that, the patient and the healthcare provider journey? And where do incentives play? What are the intersections of that? And what's really interesting to me is that some of the work that our team had done with Jeff's team a little while back, we're looking at how do we increase this, the connection between the healthcare provider journey and the patient journey. And what we uncovered, one of the things that tested really well with this was this idea of a joint treatment plan. So it fit in with a particular time point within their respective journeys, but it tied the journeys together. And it was one solution that was presented. And we've tested a lot of others that was across the journey itself as well. And all of these were matched to the psychological needs of the patient, which was really how do we build, how do I get better trust in my healthcare provider that they'll be able to give me the right diagnosis. The joint treatment plan was a favorite of mine. I know it was a favorite of Jeff's as well. It tested really well. But those are just some of the things I think, Teresa, you brought up, like some of these things don't underestimate the power that we can all have in our day-to-day to make little incremental changes that can amount to really big outcomes in the end.
I think that's a wonderful place to leave things at. Unfortunately, we're already out of time, which is unbelievable how quickly it goes. But thank you all for your thoughts. Hopefully this is the start of a conversation, and some of the ideas here can definitely be put into practice, or we can build upon them. Ada, I'm going to throw it to you to kind of close us out with next steps. But again, thank you, everyone.
Thank you, everybody, so much, panelists, for joining us today, and for everybody in the audience who has joined us as well, and for those who are watching this recording after the fact. So a video recording and a summary of the insights will be coming to your inbox. Some little snippets will be shared on social media as well, which means please, if you haven't done so already, please follow us on our social media channels. LinkedIn is a big one. Facebook, we are on Facebook and Instagram as well. You can search us up, beworks.com, and then please encourage your friends and colleagues and family members to follow us also. We have lots of great content there and insights to share. Thank you again, and looking forward to connecting with everybody again sometime later.